As a pediatrician, I'm most focused on vaccines for kids. But as a guy who's 66 years old, I'm also focused on vaccines for myself as I get older. We all are going to be facing threats of infection that could be life-threatening our entire lives. And the people at the CDC and the National Institutes of Health and various places, for my profession, the American Academy of Pediatrics, have done remarkable work at figuring out what vaccines people need at what stage of their lives, what are the reasons you should get them, what's the best spacing for them, to make these diseases so uncommon that it might seem reasonable to question whether you need a vaccine. The point is, we all do. I need my vaccines. The kids who come to my office need their vaccines. You need your vaccines to protect yourself and those you love. As a pediatrician, I'm most focused on vaccines for kids. But as a guy who's 66 years old, I'm also focused on vaccines for myself as I get older. We all are going to be facing threats of infection that could be life-threatening our entire lives. And the people at the CDC and the National Institutes of Health and various places, for my profession, the American Academy of Pediatrics, have done remarkable work at figuring out what vaccines people need at what stage of their lives, what are the reasons you should get them, what's the best spacing for them, to make these diseases so uncommon that it might seem reasonable to question whether you need a vaccine. The point is, we all do. I need my vaccines. The kids who come to my office need their vaccines. You need your vaccines to protect yourself and those you love.
Good morning, and welcome back to Day 2 of the Missouri Immunization Conference. I'm Nicole Cope, the Executive Director of the Missouri Immunization Coalition. Before we get started today, I'd like to remind you of a few housekeeping items. All attendees will be muted for the entirety of the conference, but remember, we still would love your participation. By clicking on the Meeting Hub, you can see a list of people in attendance. There, you can find your colleagues and set up conversations with them, just like you would at an in-person event. In the Resource Gallery, you can access all of the speaker presentations and exhibitor handouts. When a session is completed, please return to your timeline. From there, you can visit the exhibit hall and join the next session. We encourage you to visit all of our exhibitors. You may speak with them using the chat function, video function, or check out the resources they have available. When you visit the exhibitors, you will be entered into a daily drawing to win a door prize. including tickets to various sporting events from universities throughout the state of Missouri. If you like taking notes during the presentation, take advantage of the notes field. When the conference is over, you can email your notes to yourself, and they will be divided by each session. Please use the live Q&A section to submit questions, and we will ask the questions on your behalf. If you would like to take advantage of the closed captioning feature, please press the CC button under the video window. So let's get started. I would like to welcome our keynote speaker, Dr. Patricia Wodi. Dr. Wodi is a public health physician with the Center for Disease Control and Prevention's Immunization Services Division, located in the National Center for Immunization and Respiratory Diseases. Prior to joining the CDC, Dr. Wodi worked in clinical practice and clinical drug development for over 15 years. At the CDC, she is the co-lead for the Advisory Committee on Immunization Practice Combined Immunization Schedule Work Group, editor for the Epidemiology and Prevention of Vaccine Preventable Diseases Pink Book, provides immunization and educational resources and training to healthcare providers. She has worked on several vaccine safety research studies. Dr. Wodi holds a Doctor of Medicine degree from the College of Medicine, University of Port Harcourt in Nigeria. She is board certified in general pediatrics and pediatric infectious diseases. Dr. Wodi is going to speak with us today on the ACIP Vaccination Schedule and Heterologous Vaccination Series. Welcome, Dr. Wodi.
Thank you so much for inviting me today. It's my pleasure to present the 2022 updates to CDC's immunization schedule. Before we begin, I would like to state that I do not have any conflicts of interest to disclose, and I would not discuss vaccine products that are not approved or authorized by the Food and Drug Administration. Any use of trade names during my presentation is for identification purposes only and does not imply endorsement by the Centers for Disease Control and Prevention or the Advisory Committee on Immunization Practices, ACIP. Discussions about off-label use of vaccine products will be in the context of ACIP recommendations. And lastly, the views expressed in this presentation are those of the authors and do not necessarily reflect the official policy or position of the CDC. So on this slide is an outline of my presentation. I will go over an overview of CDC's immunization schedule, and then I'll present updates to the 2022 immunization schedules and the current COVID-19 vaccination recommendations. In addition, I will discuss interchangeability of vaccine products, co-administration of vaccinations, and vaccination resources for healthcare providers. Now, beginning with an overview of the schedule, CDC provides two separate immunization schedules, one schedule for children and adolescents to cover birth through age 18 years, and an adult schedule for age 19 years or older. Both immunization schedules are updated annually and they represent current approved ACIP policies. The schedules are designed to be a guide for healthcare providers to ensure that individuals get all the vaccines they need when they need them. The schedules are announced each year in early February as a notice to readers in CDC's Morbidity and Mortality Weekly Report, and they are published online. Both schedules are recommended by ACIP and approved by the CDC Director and the partner organizations shown on the slide. The schedules have a similar format and the content is harmonized as much as possible. Each schedule consists of a cover page, tables, a notes section, and an appendix. On the cover pages, we have a table that lists the vaccine names and abbreviations included in the schedule. We also have a box at the top of the schedules with instructions on how to use the schedule. When making vaccination recommendations for an individual patient, healthcare providers should review all the tables, the notes section, and the appendix. Now, the child and adolescent schedule has three tables. Table 1 is the recommended schedule by age. Table 2 is the catch-up schedule. And Table 3 is the vaccine recommendations by medical indication. The adult schedule has only two tables. Table 1 shows the recommendations by age group, and Table 2 outlines the recommendations by medical or other indications. Both schedules have a notes section which provide further details on the ACIP recommendations for each vaccine type in the schedule, such as the different vaccine products that are available or use of the vaccine in special populations, such as those who are immunocompromised or who are pregnant. In 2022, an appendix was added to both schedules, and the appendix lists the contraindications and precautions for all the vaccines that are included in the schedule. I will now highlight the key updates in the 2022 child and adolescent schedule, beginning with the cover page. So on the cover page, we have included a fifth step instructing providers to review the newly added appendix, which lists the contraindications and precautions for each vaccine type. In the table of vaccine abbreviations and trade names, we have added dengue vaccine. Now moving on to table 1, which lists the recommended vaccine by age. In table 1, we have also added a row for dengue vaccine with the columns for age 9 through 16 years shaded in yellow to indicate the recommended age range for routine vaccination. In addition, we've included an overlying text, seropositive in endemic areas only, see notes, to highlight dengue vaccination is only indicated for persons in this age group who are seropositive and live in areas with endemic dengue. The see notes notation is to prompt the provider to look at the notes section for additional details. In the HPV role, the previous blue color and the associated asterisk for children aged 9 through 10 years has been changed to a new checked yellow color. We've also added a new checked yellow color to the legend with the descriptive text that says, recommended vaccination can begin in this age group. This change was made to clarify that HPV vaccination can begin at age 9, and the recommendation for age 9 through 10 years is not based on shared clinical decision making. Our table 2 in the child and adolescent schedule is the recommended immunization for children who are starting their immunizations late or are more than 1 month behind. In the HIP role, the minimum interval between those 2 and 3 has been updated to include Vaxilis in the 4 weeks interval and to delete Convax from the 8-week interval. Convax was a vaccine product that was discontinued in 2014, and all children who received Convax will be past their 5th birthday by January 1st, 2022. In Table 2, we have also added a new rule for dengue vaccine showing the minimum age for dose 1 and the minimum intervals between the doses. Now, Table 3 outlines the recommended vaccination based on a medical indication. In the header, we have revised the CD4 counts and percentages from less than 15% and total CD4 count of less than 200 to less than 15% or total CD4 count of less than 200. This change was made to be consistent with ACIP's general best practice guidelines for defining HIV laboratory parameters for severe immunosuppression. The only content edit that was made to Table 3 was to add a rule for dengue vaccine, indicating that the vaccine is contraindicated in persons with immunocompromising conditions, including those with severe immunosuppression due to HIV infection. In the columns for pregnancy and persons with HIV infection who do not have severe immunosuppression, we have used the orange color to indicate the vaccine might be indicated if the benefit of protection outweighs the risk of an adverse reaction. Now, moving on to the notes section, most of the edits in this section were made to improve readability and utility of the schedule. On the first page for COVID-19 vaccination, we have provided the URL to the web page with the most up-to-date recommendations. These recommendations are revised as more information becomes available. For dengue vaccination, we have added dengue vaccination to the notes section to summarize the recommendations for routine vaccination and to also provide guidance on geographical areas where dengue is endemic. We have also provided a URL to the web page with additional information on pre-vaccination laboratory testing. Within the HIP notes, the routine and catch-up vaccination sections have been updated to include Vaxelis. We have also included a sentence noting that Vaxelis is not recommended for use as a booster dose. Now, in the special situations section of the HPV notes, we have clarified that in persons with immunocompromising conditions, a 3-dose series should be administered, even in those who begin their vaccination series at age 9 through 14 years. And in the influenza vaccination note, we have really condensed that by moving all the contraindications and precautions for influenza vaccine to the newly created appendix. And then we included information on the recommendations for the 2021-22 influenza season, which is about over. Now, in the MMR notes, in the routine vaccination section, we have included some information on the use of MMRV. This includes clarifying that for children aged 12 through 47 months, it is recommended to administer dose 1 as separate MMR and varicella vaccines. In this age group, MMRV may be used for dose 1 if parents or caregivers express a preference. And in the catch-up vaccination section, we have included a new bullet with information on the minimum interval between dose 1 and 2 of MMRV. Now, a small edit in the meningococcal ACWY note was made to clarify that ACWY vaccines may be administered simultaneously with B vaccines if indicated, but at different anatomic sites. And then similar to the MMR notes, in the varicella notes, we have included the use of MMRV and also stating that for children aged 12 through 47 months, it is recommended to administer dose 1 as separate MMR and varicella vaccines. However, MMRV may be used if parents or caregivers express a preference. In the catch-up vaccination section, we have clarified that a second dose of varicella vaccine inadvertently administered after at least a 4 weeks interval may be counted as a valid dose. In the appendix, which was newly added in 2022, at the top, we have included statements for how the appendix was created. This was adapted from ACIP's General Best Practice Guidelines for Immunization and from the 2021-22 Influenza Vaccine Recommendations. We have also included the URL to the web page for CDC's interim clinical considerations for use of COVID-19 vaccines, because that's where you would find the most up-to-date information on contraindications and precautions for COVID-19 vaccines. So the first page of the appendix is a list of the contraindications and precautions for each type of influenza vaccine. And the second page lists the contraindications and precautions for non-influenza vaccines. Now, moving on to the updates to the 2022 adult schedule. Some of them are similar to the changes we made in the child and adolescent schedule. However, there are key content edits for hepatitis B, pneumococcal, and zoster vaccination that are based on the recent ACIP recommendations for the use of this vaccine. So just like we did in the child and adolescent schedule, we have also updated the how to use instruction box with a fourth step, instructing providers to review the newly added appendix that lists the contraindications and precautions before making vaccine recommendations. In the table of vaccine abbreviations and trade names on the cover page, we have removed PCV13, Prevnar 13, and we have included the two new pneumococcal conjugate vaccines, PCV15 and PCV20, that are recommended for adults. Now, Table 1 in the adult schedule is a routine vaccination by age group. Now, in the recombinant zoster vaccine role, we have made changes to reflect the new ACIP risk-based recommendations for use of the vaccine in adults aged 19 years through 49 years. So we've noted that 2 doses of the recombinant zoster vaccine is now recommended for adults in this age group who have immunocompromising conditions. The roles for pneumococcal vaccines have been condensed into a single role, so we no longer have separate roles for the pneumococcal conjugate vaccines and the polysaccharide vaccines. They are now in a single role. We have also used the purple bar to indicate the risk-based recommendations for persons aged 19 years through 64 years. The yellow bar indicates routine vaccination for persons aged 65 years and older. In the hepatitis B role for age 19 to 59 years, we now use the yellow bar to reflect ACIP's recommendations for universal hepatitis B vaccination in this age group. And then for those 60 years and older, they will continue to have the risk-based recommendations, which we have indicated with the purple bar. Now, moving on to Table 2, which is the recommendation based on medical indication. There's a minor edit to the header for HIV infection, which we now include the CD4 percentages in addition with the count, and that was just to harmonize with the way we present it in the adult and child schedule. Now, for live attenuated influenza vaccine, MMR, and varicella vaccines, the overlying text now says contraindicated as opposed to not recommended, which is a better reflection of ACIP's recommendation not to use these vaccines in adults who have those underlying medical conditions. Notice that for HPV, the overlying text still says not recommended for pregnancy, which is a better reflection of ACIP's recommendation that HPV vaccination is not recommended for use in pregnancy. In the pregnancy column, you will also notice that we've put some asterisks that links to the legend in the red box that says that those vaccines could be administered after pregnancy. Now, in the recombinant zoster vaccine role, we have highlighted 2 doses of this vaccine is now recommended for adults aged 19 years and older who have immunocompromising conditions, including HIV infection. Now, for all the other medical conditions and indications in the table, the minimum age for herpes zoster vaccine remains 50 years. In the pneumococcal vaccination role, we have used the yellow color to indicate routine vaccination based on our medical indication. And then the purple bar indicates the indication where the risk-based recommendation applies. And then for the hepatitis B role is now entirely yellow to indicate the vaccine is recommended for persons who have any of the indications listed in the header. Moving on to the notes section, in the adult schedule, we also have COVID-19 vaccination information displayed in the same way like we do in the child and adolescent schedule, which is basically to direct healthcare providers to the web page that contains the most recent recommendations. Now, in the hepatitis B notes, we have made updates to reflect the new recommendations. So in the routine vaccination section, we have language for universal vaccination for adults aged 19 through 59 years. We've also included some more detailed descriptions for use of the 2, 3, and 4 dose series and where those are indicated. Now, in the special situations section, we have described the risk-based recommendations for adults who are 60 years of age and older. Now, at the end of the hepatitis B notes section, we have included a sentence that states that anyone who is 60 years of age or older who does not meet the risk-based recommendations but would still like to get the vaccine may be vaccinated. Now, moving on to the Hpv vaccination notes, which goes across 2 pages. We have clarified the final bullet in the routine vaccination section, and it now reads that no additional dose recommended when any HPV vaccine series has been completed using the recommended dosing interval. And in the special situation section, just like we did in the child schedule, we have clarified that persons with immunocompromising conditions should receive 3 doses of HPV vaccine, even those who are initiating vaccination at age 9 through 14 years. In the influenza notes, we have condensed this by moving most of the information on contraindications and precautions to the newly created appendix, and then we included the URL to the web page for the 2021-22 influenza recommendations. Now, in the meningococcal vaccination notes, we have added some information on simultaneous administration. So MenB vaccines may be administered simultaneously with meningococcal ACWY vaccines if indicated but at different anatomic sites, if feasible. In the pneumococcal vaccination notes, we have changed this entire section based on the new recommendations from ACIP to use PCV15 and PCV20. So in the routine vaccination section, we have a bullet for those aged 65 years and older who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown. They should receive 1 dose of PCV15 or 1 dose of PCV20. If PCV15 is used, this should be followed by a dose of PPSV23. Guidance on the dosing interval between PCV15 and PPSV23 is also provided, which is at least 1 year. However, a minimum interval of 8 weeks may be considered in those who have immunocompromising conditions, cochlear implants, or cerebrospinal fluid leak. We've also provided a link to the web page with guidance for patients who have previously received PCV13 with or without PPSV23. And then in the special situation section of the pneumococcal notes, this is where we have the risk-based recommendations for adults who are aged 19 through 64 years. So for those who are aged 19 through 64 years with certain medical conditions or other risk factors who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown, they should get 1 dose of PCV15 or 1 dose of PCV20. And if PCV15 is used, then this should be followed by a dose of PPSV23. And we also have the guidance for the intervals between PCV15 and PPSV23. and the same URL to the ACIP policy note that includes guidance for patients who have previously received PCV13 with or without PPSV23. And finally, at the end of that section, we have a list of the underlying medical conditions or risk factors that would make those aged 19 through 64 years eligible to receive pneumococcal vaccination. In the zoster vaccination section, where we have the special situation, we have clarified the pregnancy bullet to state that there's currently no ACIP recommendations for use of recombinant zoster vaccine in pregnancy, and to consider delaying vaccination until after pregnancy. The bullet for immunocompromising conditions have been updated to reflect ACIP's most recent recommendation, which is that recombinant zoster vaccine is recommended for use in persons aged 19 years or older who are or will be immunodeficient or immunosuppressed because of disease or therapy. The appendix in the adult schedule is similar to that in the child schedule. We have the same statements at the top showing that it's adapted from ACIP's General Best Practice Guidelines for Immunization and the 2021-22 Influenza Vaccine Recommendation. The first page also lists the contraindications and precautions to influenza vaccines. And the second page lists the contraindications and precautions for non-influenza vaccines. Okay, now turning our attention from routine vaccination to COVID-19 vaccination recommendation. Starting with a high-level overview, COVID-19 vaccines are recommended for everyone ages 5 years and older in the United States to prevent COVID-19 illness. The vaccines currently approved or authorized by FDA are effective in preventing serious outcome from COVID-19 illness, including severe disease, hospitalization, and death. The vaccines are safe, and the known benefits of vaccination continue to outweigh the possible risk of an adverse reaction to vaccination and the risk of COVID-19 illness. Efforts to increase the number of people who are up to date with their COVID-19 vaccination series remains critical to preventing illness, hospitalization, and death from COVID-19 illness. Currently, there are 3 COVID-19 vaccine products that are approved or authorized by the FDA, and all 3 vaccines are non-live vaccines. The Janssen vaccine is a replication-incompetent viral vector vaccine, and Moderna and Pfizer products are mRNA vaccines. Now, the mRNA vaccines are preferred over the Janssen vaccines for primary and booster vaccination in all populations. On this slide is a URL to a web page that contains detailed information for each COVID-19 product and other resources for storing, preparing, and administering the products. The recommendations for COVID-19 vaccines vary by age group and the degree of immune suppression. Now, for children, the rule of thumb is that they should receive the age-appropriate vaccine formulation and follow the schedule based on their age on the day of vaccination, regardless of their size or weight. Now, to prevent barriers to accessing COVID-19 vaccines for people who are moderately or severely immunocompromised, CDC recommends that these individuals or their parents or guardians can self-attest to their immune status wherever vaccine is offered. They do not need to provide documentation of their immune status, and they should not be denied COVID-19 vaccination due to lack of documentation. Individuals who have questions about their immune status can discuss with their healthcare providers to determine which COVID-19 vaccination schedule is appropriate for them. CDC offers a pre-vaccination checklist, which is shown on the slide, where people can check if they consider themselves moderately or severely immunocompromised. This pre-vaccination checklist can be found online using the link at the bottom of the slide. So on this slide is a summary of COVID-19 vaccination recommendations for persons who are not moderately or severely immunocompromised, and I'll just walk through each row. Now, for those aged 5 years and older who are not moderately or severely immunocompromised, they should receive a primary series consist of 2 doses administered 3 to 8 weeks apart. After completing their primary series, everyone should receive a booster dose at least 5 months after completing the primary series. Now, for persons aged 50 years and older, a second booster dose is recommended at least 4 months after the first booster dose. Now, for Moderna vaccine product, this is approved for ages 18 years and older. The schedule is similar to the Pfizer vaccination schedule. However, the interval between the 2 dose primary series is 4 to 8 weeks. Everyone who is using the Moderna vaccine products should get a 2 dose primary series, and at least 5 months after completing the primary series, they should get their first booster dose. Now, for people who are 50 years of age and older, they should also get a second booster dose at least 4 months after their first booster dose. And for Janssen vaccine, the primary series consists of a single dose, and a booster dose is recommended at least 2 months after the primary series. For the first booster dose, an mRNA vaccine is preferred over the Janssen vaccine. Now, for a second booster dose, using an mRNA vaccine is recommended for people who are 50 years and older. This second booster dose may also be given to those 18 years and older who received 2 doses of Janssen vaccine. Now, on the previous slide, we saw that the interval for the primary series for mRNA vaccines in persons who are not moderately or severely immunocompromised is a range 3 to 8 weeks for Pfizer vaccine and 4 to 8 weeks for Moderna vaccine. The shorter interval is most appropriate when the fullest possible protection needs to be achieved as soon as possible. And some situations where this may apply is if you have a high COVID-19 community level, adults aged 65 years and older, an individual who is at high risk of severe disease. On the other hand, the longer interval may be most appropriate in situations where you want to reduce the rare risk of myocarditis. This may be important in males who are between the ages of 12 and 39 years. And another situation is where we want to optimize vaccine effectiveness, because increasing the interval may increase the vaccine effectiveness. However, there is no indication that extending the interval beyond 8 weeks is beneficial. Now, moving on to the recommendations for persons who are moderately or severely immunocompromised. The recommendations for this population differs from those who are immunocompetent because they are at increased risk of severe COVID-19 illness and most likely to have serious breakthrough infections. They are also less likely to mount a protective immune response after completing the 2 dose primary series. And in general, they have a lower vaccine effectiveness than people who are immunocompetent. Now, for children who are between the ages of 5 to 11 years and are moderately or severely immunocompromised, they should receive a total of 4 doses using only Pfizer vaccine. This is the only product currently approved for children in this age group. The series consists of a 3 dose primary series, followed by a booster dose at least 3 months after completing the primary series. Regarding the intervals, you will note that the interval between the first and the second dose is 3 weeks and is not a range as seen in those who are immunocompetent. Also, the interval between completing the primary series and the first booster dose is at least 3 months. Now, for those who are 12 years and older and have conditions that make them moderately or severely immunocompromised, if using the Pfizer vaccine, they should receive a total of 5 doses, a 3-dose primary series, and 2 booster doses using the intervals shown on the slide. Our Moderna vaccine is approved for ages 18 years and older, and those who are immunocompromised should receive a total of 5 doses, which consists of 3 dose primary series and 2 booster doses. Now, for Janssen vaccine recipients, they should receive a total of 4 doses. The primary series should be followed by an additional dose of an mRNA vaccine 4 weeks later, and then they should receive 2 booster doses using the intervals shown on the slide. Now, on this slide, I have put the link to the web page that has the most recent recommendations for using COVID-19 vaccines. This web page is constantly being updated as more information becomes available. You can see that the last update was on May 20th, 2022. I have also highlighted the COVID-19 schedule at a glance, which is a helpful visual to have summarizing the COVID-19 vaccination schedule by age, vaccine product, and immunocompromised status. On this webpage, you can also sign up to receive email updates whenever changes are made to the page. Next, I will discuss interchangeability of vaccine products from different manufacturers. Sometimes we have individuals who come to us to complete a vaccination series that they began with other providers. So many vaccines recommended for a specific disease have multiple products available in the US. So, for example, hepatitis A, hepatitis B, meningococcal ACWY, and even MenB have multiple products available for use in the US. FDA approval of a vaccine product does not necessarily indicate that a vaccine is interchangeable with other products that are available. Vaccine manufacturers use different production processes. Their products may contain a different type of antigen, or concentration of antigen, or different stabilizers or preservatives. So ACIP has provided general rules for interchangeability, and this can be found in the general best practice guidelines using the link at the bottom of the slide. So preferably, doses in a vaccine series should come from the same manufacturer. If this is not possible or the manufacturer of the previous doses is unknown, providers should administer the product that they have available. Vaccination should not be deferred because the brand used for previous doses is not available or is unknown. If different vaccine products are used in a series, the higher number of doses is recommended to complete the series. So, for example, for rotavirus vaccination, if Rotatech is used in the series or there's a dose that was given that the brand is unknown, the infant should receive 3 doses of rotavirus vaccine. So, looking at interchangeability of COVID-19 vaccine products, the general rule applies. So the same mRNA vaccine product should be used for all doses in the primary series. Well, however, we acknowledge that there are exceptional situations. So an exceptional situation can be that where the first dose of the mRNA product in the series cannot be determined or is unavailable. In that situation, CDC recommends that any available mRNA vaccine products may be administered at a minimum of 28 days interval between the doses to complete the primary series. And another exceptional situation is where the first dose of the mRNA vaccine given is known, but we're unable to give this patient another mRNA vaccine, either the same brand they received or a different brand. And a situation like would be where when there's a contraindication to mRNA vaccine. So in this situation, a single dose of Janssen vaccine may be considered at a minimum interval of 28 days from the mRNA dose already received. And if the patient is 18 years and older, because Janssen vaccine is only approved for 18 years and older. Now, if this occurs, people who receive the Janssen vaccine after the mRNA dose should be considered as receiving a valid single dose of the Janssen primary series. Now, for non-COVID-19 vaccine products, the general rule also applies. So it's preferred to use the same product, but if unavailable or unknown, all brands of rotavirus, Haemophilus influenza type B, hepatitis A, hepatitis B, and meningococcal ACWY vaccines are interchangeable within their respective series. Now, I'll talk a bit more about interchangeability of hepatitis vaccine products. We have a single antigen hepatitis A vaccine and single antigen hepatitis B vaccines available. In addition, we have a product that is a combination of hepatitis A and hepatitis B vaccine. It's sold as Twinrix and is approved for and recommended for use in ages 18 years and older. Now, the single antigen hepatitis A and hepatitis B vaccines may be used in conjunction with Twinrix, the combination vaccine, to form a complete series. However, the hepatitis B component in Twinrix is similar to the standard adult dose single antigen hepatitis B vaccine. So the schedule is the same regardless of which vaccine is used. However, the hepatitis A component in Twinrix is similar to the pediatric dose of hepatitis A. So the schedule will be different if the series is mixed with hepatitis A and Twinrix vaccine. And on this slide, I have provided some more information about interchangeability of hepatitis A products that include Twinrix vaccine. So if the series begins with single antigen hepatitis A vaccine, you can complete the series with 2 doses of Twinrix. If a patient has received 1 dose of Twinrix, you can complete the series using 2 doses of single antigen hepatitis A vaccine separated by at least 5 months. And then for those who receive 2 doses of Twinrix, they can complete the hepatitis A series with 1 dose of the single antigen hepatitis A vaccine. And this information can be found in ACIP's policy notes for the use of hepatitis A vaccines. Now, for meningococcal vaccine products, like I mentioned earlier, for men ACWY products, if the general rule applies, so the same vaccine product is recommended to be used in the series. But if the previous product is unavailable or unknown, then the products are interchangeable. However, for meningococcal serogroup B vaccines, those products are not interchangeable. The same vaccine must be used for all doses, including the booster dose, to ensure that the individual is adequately protected against meningococcal B disease. Now, for co-administration of vaccines, I wanted to provide a little bit of guidance because often individuals need more than 1 vaccine during the same clinic visit. So co-administration of vaccine is also called simultaneous administration of vaccine. Is defined as administering more than 1 vaccine on the same clinic day at different anatomical sites. The table on the slide is a helpful summary of CDC's recommendations for co-administration of vaccine, and it can also be found in the general best practice guidelines for immunization. So, in summary, if two or more non-live vaccines are to be given, they can be given on the same day or at different or using any interval. So, for example, two non-live vaccines will be Tdap vaccine and hepatitis A. They can be given on the same day if the patient is eligible, or they can be given at any interval. It doesn't matter. And this is also the same for when you're giving a non-live vaccine and a live vaccine. So, for example, if the patient needs an MMR vaccine and a hepatitis B vaccine, the MMR vaccine is a live vaccine and the hepatitis B vaccine is a non-live vaccine. They can be given at the same clinic visit or at any interval. However, if two or more live injectable vaccines, such as MMR and varicella, to be given to a patient, if they are not given on the same day, they must be separated by at least 28 days to prevent interference between the live vaccines, interference to the immune response between the live vaccines. Now, all COVID-19 vaccine products approved or authorized by the FDA are non-live vaccines, so they can be administered without regard to timing if they have to be given with other vaccines. So they can be given as the same day with other vaccines or at any interval. Lastly, I would like to share some helpful resources for healthcare providers that the CDC has put together. This is a list of resources to help healthcare providers with interpreting the immunization schedule. I have also included the URL to the web pages where you can get more information. The first is the Immunization Schedule App, which you can download on your mobile device. It includes the adult immunization schedule and the child and adolescent immunization schedule. You can also have access to the contraindications and precautions for all vaccines in the schedule. And there's a tab that includes vaccination resources, which can be quite helpful. The next resource is the Job Aid, or we also call this the Catch-up Vaccination Guidance. This is specific for children and adolescents, and is to help with interpreting Table 2 in the immunization schedule, which is a catch-up schedule. These are PDF documents, and they are flow charts, and they can walk you through from how many doses the child or adolescent has already received to what they need at the moment and what they would need after that. The Pneumococcal Vaccination App is specific for adults 19 years and older. It includes recommendations for the pneumococcal vaccines that the ACIP has, the latest recommendations for pneumococcal vaccination in adults. And if you input the patient's information, including age, medical history, and the previous doses of pneumococcal vaccine they have received, then you will get an output telling you what the patient needs, which pneumococcal vaccine, if any, the patient needs. And the next is the pneumococcal vaccine timing for adults. This is also a PDF and it's a nice visual with information on how to interpret ACIP's current recommendations for pneumococcal vaccination in adults. And then I have talked about the interim clinical considerations for use of COVID-19 vaccines. And I'd like to emphasize that it's very important if you're administering COVID-19 vaccines, very important to go to that web page as we get more information, that web page is frequently updated. And lastly, I have included the storage and handling toolkit because storing, preparing, and administering a vaccine is it's very important in ensuring that we have a safe and effective immunization program. And on this slide, we have the training resources for healthcare providers, and continuing education is available. There are self-studied modules like the You Call the Shots program, and we also have webinars such as the Pink Book webinar and the current issues in immunization webinar. And the URL at the bottom of the slide will take you to the web page where you can get more information about this product. And if you need further assistance about immunization or vaccine preventable diseases, you can call us using the phone number on the slide or email us at nipinfo@cdc.gov. I've also included another email address which is specific for US healthcare providers who have quite complex vaccine safety questions about a patient who resides in the US. The Clinical Immunization Safety Assessment Project provides consultations to US healthcare providers if they have a patient with a complex vaccine safety question that is not readily answered by ACIP policy note. So you can send them an email using the email address on the slide. They would need to assess the patient's medical records, and the process takes about 4 to 6 weeks, so it's not quick. So that's the end of my presentation. Thank you so much for listening, and I'll now take questions.